So we saw in our treatment and management of patellofemoral pain syndrome that taping could help, and taping will relieve pain and enable the patient to engage in rehabilitation at an earlier stage. We described two forms of taping. The first was a medial glide taping, and that gave the impression that the kneecap was moving to one side, in this particular case to the inside of the body, the medial aspect. And the second taping that we did was a V taping, and that took some pressure off the patellar fat pads, which were those two little sponges either side of the kneecap tendon below the knee joint itself. So let's begin by looking at our medial glide taping for patellofemoral pain syndrome. So we've got three components for our taping here. The first is a mesh open weave tape, which just protects the skin, enables it to breathe a little bit. And the second one is our zinc oxide tape, which has a much stronger adhesive, so it doesn't tend to go straight on the skin, but it's also a firmer, rigid tape, and obviously a pair of scissors just to cut it. So we're going to take the taping from the outside of the knee in towards the inside, and I'm going to firstly measure the distance that I need for my taping under wrap. So I'm using this mesh tape just to protect the skin, and going to put it over the parts of the skin where I'm going to put the stronger zinc oxide tape. So it just lays onto the skin, and I'm using two pieces of tape, and the upper one will finish at mid patella and the lower one starts at that point. So that's our skin preparation. And then I'm using my zinc oxide tape, and this is serrated at the edge so you can actually tear it, and it's tearable tape is used particularly in sport. As I place it on, I put it onto the edge of the skin, and then I drag it into a medial direction. Now I've deliberately put a little bit of the zinc oxide on the skin there, but most of it is on the under tape. So again, placing the taping on, dragging across. And what we've done there is just to stretch the skin laterally, loosen the skin medially, so that as we start to do exercise, it's almost as though I'm following the patient around and I'm gently pressing the patella medially. And if you remember, we said that we had a couple of tests that were key for our patellofemoral pain syndrome. One was palpation of the lateral aspect of the patella, and the other was the performance of a squat or a single squat movement. And if that was painful and I can press the kneecap medially and it reduces the patient's pain, then I can use this taping, which then gives the patient that impression of a medial force, a medial glide onto the patella. For our V tape, we're palpating below the aspect of the patella, and we're going either side of the patella tendon into the fat pads. And if those fat pads are painful, then we can use this taping to try to lift the patella up away from the fat pad and take away any stress. So I start off with an under tape, and I'm measuring the tape itself. All I then do is to take the backing off the tape and lay the tape where the zinc oxide is going. So it's going to go from this small bump on the tibia, which is our tibia tubercle, and then it's going to go in the same from the same position over the tibial tuberosity laterally so that we form a V shape. So there we've got our under tape, and the V has the patella in between the two arms. So I then have my zinc oxide tape, which I can tear. I'm going to measure the distance, so I don't want to measure it with the adhesive side, so I'd measure with the non-adhesive side, and then I can make sure that I have the right amount of tape, place it into the lower portion, and then drag the skin upwards to give that feeling of support on the kneecap. And again, back of the tape to measure, place it in the lower portion, hold that, drag it upwards. Now with this taping on, if you want to make it stronger, then you would just put a second piece overlapping the first by 50%. In this case, because I'm quite close to the kneecap, I'm going to put it laterally, so it's overlapping by 50% laterally. And so I've got my V shape there. It'll take time for the adhesive to soak into the follicles on the skin and just to adhere to the skin. So we've got two strands of our V tape then, medial and lateral with the patella beneath, and then that supports the kneecap and just pulls it upwards. As I bend and straighten the knee, we've only got about 30 degrees of movement. Any more than that, and you'll find that the tape will pull away from the skin. But if the patient can flex to 90 degrees, the chances are that this taping is not appropriate.